welcome to Posterior Labral Repair Tips and Tricks. This video is designed to give you some help doing what is quite a technically complicated operation. It's designed for people who are learning how to do posterior labral repair or are interested in posterior labral repair. Please note that this is my way of doing it. These are my thoughts. There are other ways, and if you're going to do this operation, you take what works for you. So just a little bit on posterior labral tears. Typically they're a fall onto the outstretched hand or a direct blow forcing the shoulder backwards. Classically, the ones in my practice come from rugby players, although we do obviously see posterior dislocation with the classic fits and electric shocks. There is a spectrum of the pathology in the literature, and it can be part of a multi-directional instability, and you occasionally see it in throwing athletes as more of an attritional problem. The first problem we encounter with posterior labral injuries is the diagnosis is often not obvious, and it's easily missed, and there's often quite a long delay to presentation to somebody who will pick this up and start to treat it. The shoulder is rarely unstable in the sense that it dislocates. It has a feeling that it may be unstable, that the shoulder is moving awkwardly. They often get an ache, and certainly in the rugby players they describe burners and stingers because those are the only words they know to describe a problem around the shoulder. There's often a dead arm feeling if they have an impact. They often can't carry on playing, but it resolves spontaneously over a few days and they're back to normal until they do it again. Clinically, there is often little to find. They may have posterior joint line tenderness in the more acutely injured patients. Posterior glide may cause pain, but not always. And if you do the Job's posterior test where you load the back of the labrum, that can be positive, but may not always be. And interestingly, if you do the O'Brien's and Kim's test for a slap lesion, that may pick up a posterior labral tear, but again, not always. Imaging typically is in the form of an MRI or an MR arthrogram, and they're not easy to see. You may get these hidden Kim lesions where there may be just a small defect within the body of the labrum rather than a frank labral tear. Often the labral tear looks fairly insignificant on the MRI, but when you get in there arthroscopically, the damage can be much more significant, and this MRI and this arthroscopic picture are both of the same patient taken a couple of weeks apart. Once you've made the diagnosis and you've decided to operate, there are a number of issues with posterior labral tears that people struggle with. Firstly is getting the access around the back of the shoulder, managing the sutures in the back of the shoulder, and also the whole thing about working back to front. It's not something we typically do and something that people often struggle with. There is no doubt that this operation is much easier in the lateral position. So this is the way I set things up. I start by standing behind the patient in the standard way, the assistant typically at the head of the patient and looking straight forward to the camera stack. Start by doing a standard diagnostic arthroscopy from the posterior viewing portal, and in most cases you'll be able to see the posterior labral tear, although sometimes there's a flap of tissue that gets in the way. And in this poor patient, there is also quite a significant chondral defect from the trauma of the original injury, which happened a few weeks before. really the only way to view posterior labral pathology is from the front of the shoulder, and therefore you need to reverse the instruments. The easiest way of doing this is to make an anterior portal and pass a switching stick through the rotator interval. You can then load the switching stick into the trocar and simply remove the trocar, pass it over the switching stick from the other direction, and then you're into the joint looking from front to back. At this point, the easiest way to operate is to move yourself round. If you stand at the back and operate trying to work at the back, your triangulation's off, everything's in the wrong place. If you now move yourself around to the head of the patient, you're then effectively working in reverse. If you've got one monitor, then you just have to rotate it round and you accept that you're looking a little bit over your shoulder. If you can arrange two monitors, then obviously you put it down where the scrub nurse now is, and that makes your life much, much easier. But it's only in this way, with standing at the head of the patient, that you're operating the right way round and your triangulation becomes so much easier. It's worth taking a moment to think about the arthroscopic portals. Obviously your scope will be in the anterior portal. You have the original posterior portal, which should be about the level of the glenohumeral joint, but will often be a little bit superior in relation to the tear, because this is where you put it in. You're therefore going to need some form of portal a little bit further down towards the axilla, and typically this is going to be percutaneous. And then you need a working portal which has to be perpendicular to the glenoid itself. So this is actually quite a lateral portal, which often people make a mistake and they put it more posterior, but this needs to be pretty vertical in relation to the glenoid. I will typically put a passport cannula into the working portal, although sometimes in a very large patient you can't do this, and you therefore just have to modify the way that you manage your sutures. The percutaneous portal, I'm going to use a straight micro suture lasso. This is effectively a very rigid spinal needle with a nitinol wire in it. And I'm going to use that to pass, as you'll see, the nitinol wire through the labrum. The original posterior portal is then going to be used for wire and suture retrieval, and this is just a percutaneous portal. Just as with an anterior stabilization, the first thing to do is to plan your portal as we previously discussed to make sure you've got the access, and then elevate the labrum. And this is done just as before with an elevator. You can do this even before you put the cannula in. With an anterior stabilization, you often have to get a big shift. This isn't the case with the posterior. You just need to do enough to elevate the labrum and allow it to move so that you can get your needle underneath it and put it back where you want to put it. And you're coming in quite vertical, but it is possible to do it. And you need to make sure that you've prepared a little bit of the glenoid face so that the labrum has something to stick back onto. The next step, just like an anterior stabilization, is to prepare the glenoid with a shaver or a rasp. The shaver can be a little bit tricky as you're coming in quite vertically, as you can see, but take your time, don't use the suction unless you absolutely have to, and clear out all the debris. Remember, there's quite a lot of chondral damage associated with this, and you'll need to free up any loose cartilage as well to give yourself a good bony bed for the labrum to stick back onto. The next step is to insert the first anchor. I use the Arthrex 1.8 knotless fibre tack anchors. So this is passed down through your working cannula. And remember, you're not trying to get a shift here. So this is going to come in fairly low in your labral tear, which is typically about the sort of 7 o'clock position. So pass the guide down through the cannula, give it a little bit of a tap with a hammer just to secure it. You then drill and then pass the anchor in. The next step is to pass this blue working suture through the labrum. So use the micro suture lasso, pass it through your percutaneous portal and then through the labrum, leaving that little bridge between the labrum and the capsule. You then deliver the nitinol wire into the joint and retrieve both the blue suture, making it slide, and the nitinol wire through your original posterior portal. Just pull both of these out together. The best bet is to pull them both just out of the joint and then retrieve the sutures and the wire independently, just so that you don't get into any trouble. You're then going to load the suture into the loop and then pull the loop out, passing the suture through the labrum. Now take the retriever, pass it through the cannula and pick up that suture outside the labrum and take it back out through the cannula. The 2 white striped sutures are going to be your shuttling sutures. One has a loop on it. Load your blue working suture through the loop, which is the skinny one, and then pull the other one, as you can see here, through the blood. It's now pulling the whole mechanism through the anchor. You'll see the working suture coming down through the anchor and then tightening down. So there it is in place. And when you give it the final tug, it pulls the labrum into position. You can then cut the free end, and that's the first anchor repair complete. The second anchor is inserted in the same fashion. So pass the guide down through the cannula into the position you want, tap it into place, drill, insert the anchor and remove the cannula. The straight micro suture lasso is then passed through the capsule and under the labrum, remembering to leave a little bridge between the two. And the advantage of using this particular device is you can lift up the labrum as it's quite stiff. Deliver the wire into the joint, and once you've delivered enough, you can remove the needle entirely if you want. From your first posterior portal, use a grasper to retrieve the blue working suture, and you want this to slide. Then grab the nitinol loop with the tip, making sure you get a firm grip before you pull, and then gently retrieve both out through your first portal. Load the blue suture into the nitinol wire, Once it's loaded, you then pull on the other end of the wire and you will see the blue suture passing under the labrum. Now bring the grasper in through your cannula and retrieve that blue suture from between the labrum and the capsule. And on this occasion, we've taken the loop at the same time, which you don't have to do if you're using a cannula, but if your cannula fails, you will need to manage your sutures in this way. You now know you've brought both out at the same time with no tissue bridge. You can load the blue suture into the loop on the white suture and then pull the other end of the white suture. That brings the blue one down, locking it into position, and then a final tug to secure it. You can then cut the free end and the second anchor is completed. If you want to put a third anchor in, this is done in the same way. Put in the anchor cannula, tap it into place, drill, tap the anchor down, and then remove the guide, leaving the anchor in place. You can give it a little tug just to make sure it's secure. As before, the next step is to pass the straight micro suture lasso. And again, the key feature here is to pass it through the capsule, leave a bridge, then go under the labrum. Deliver the nitinol loop. And once you have enough, you can remove the cannula before passing the grasper through your first portal, sliding the blue and grabbing the nitinol wire. You then load the blue into the loop of the nitinol wire. And once you've done this, you can pull the wire back out through the other portal. The blue suture is now under the labrum. Then retrieve the blue suture back out through the cannula. And you want this to slide. Load the blue suture into the loop of the white suture. And then pull on the slightly broader one, and this will bring the blue suture down over the top of the labrum and into the anchor, locking it. And once you've tensioned everything, cut the end of the suture and the repair is now complete. Hopefully this video has helped you a little bit. So consider the diagnosis, particularly when patients describe this dead arm or the burners, stingers, and often don't recall a major injury, particularly contact athletes. Certainly consider, if you're going to do the surgery, doing it in the lateral position, as it makes life much, much easier. Remember to move around the patient, make life easy for yourself. If you set yourself up so that you're sort of operating in the way that you normally recognise, your triangulation gets better. And there's no doubt that knotless anchors make your life much easier in these. Tying knots, not only is it more difficult, but you leave a knot stack and they do seem to abrade on the back of the humeral head because you can't get them out of the way. So go knotless anchors. I hope you found this useful.